thematic pattern. So I can have what I call it oval flap or elliptical flap. You can change the direction of the ovality of this flap according to the axis of the astigmatism, whether it's against the rule or with the rule. And you can see here the video of showing the oval flap. You can see that it's slightly horizontal, and I change the location of the hinge according to the axis of the astigmatism. I started using this like 10 years ago, and now this is an oval flap, as you can see, and you can see this is after reposition of the flap. And what I'm doing right now is I'm using a wide hinge flap. The wide hinge flap, I even go for 5.5 millimeter. I believe this gives the flap more stability. You just do the wide hinge flap, as you can see here. This is my hinge, actually. Theoretically, you cut less nerve layers, nerve fibers, so theoretically you may end up with less dry eye. Lifting the flap is easy, and no problem with lifting the flap, and even with laser, because you have seen everything on the screens that the laser will hit on the stroma. The thing is, this is a difficult case because you have some sort of bleeding, so you need more wash so the stroma is hydrated, the flap will hydrate, but putting back the flap is extremely easy because the wide hinge doesn't let you move from side to side, it gives you less stray. So I'm using the wide hinge flap for almost every case except for hyperops. As you can see here, even for myopia, not just for astigmatism, you can use the wide hinge flap. Okay, I'll go for some complications. We used to have this sort of complication when the laser head is going to be replaced, and sometimes you face sticky flaps like this one. What I'm doing, if you have a sticky flap like this, I'm trying to divide the resistance. So I start with dissecting the easily dissected areas, and then not to have the whole resistance with one movement. So I divert the flap afterwards, so I have this sticky area. This one, like we're discussing, if you have an OBL with Visomax, this is with FS200, not with Visomax, but I got this experience with both machines. So you just have one minimal resistance, and then you can dissect it bluntly with no sharp instruments, because sharp instruments, if you are not experienced like Dr. Noel, you may end up with making a buttonhole or cutting the flap. Another case, and I'll go to the floor. This is the case of the famous suction loss. You start doing your laser surgery, the femtosecond step, and then the patient moved a little bit, so you stop. What will you do for this patient? We start with Dr. Mazen.
Yeah, because it did not cross the pupil. Yeah.
Okay.
So for me, I usually wait maybe 1 hour. This will disappear, and then I redo. But maybe in this machine, I don't know about redoing the 1 hour, but I'm talking about Visiomax.
Okay.
I can redo very smoothly after 1 hour, very smoothly.
Dr. Hosni have an experience with all machines in the world, so with FS200, what's your experience?
I would redock and redo the after like 1 hour, exactly like Dr. Mazen said. But my honest advice is get the ZA.
Okay.
Get the ZA.
Would you use the same cone?
This was used to be the case with intralace. This was classic teaching because each cone has a different imprint than the
same
other.
for FS200.
You can use the same cone if you have an extra cone that you'd like to use. You will not have 2 levels. This is something that never happens. Provided that you do not attempt to elevate this at all.
Of course, there is no side cuts even.
You'll have only one.
Dr. Nobel?
I would do the same. So redock. And so since we use the Visomax, you know that you have different pattern. So, because it's circular. So if you have a stop of a suction loss in the first phase, the pupil is always paired. So I would do a redocking in 1 hour.
Would you use any different configuration of the initial flap? Increase the flap diameter? Or?
Just to be sure, if you want to be on the same size, if you change some parameters, so if you can do a different thickness and a different size, it's better, because you know with the Visumax it's not easy to redock in the same place.
Exactly.
That's why if you enlarge the flap and you get the flap deeper, for example, you're sure you're not crossing the two lamellar dissection.
What I actually do is using the same flap thickness and a little bit wider flap, but I would change the canal placement because the canal is already open. If you have this air bubble in the AC, how would you manage it? Have you experienced an air bubble in the AC with the Visumax?
In the AC? No.
Source A.
With FS200, every 10 cases, you get one of those.
Not everything.
10 cases.
This was the old laser head, by the way.
Okay.
But now it's not that common. But I used to see it like 10 years ago, maybe. But now it's not anymore. But the problem is with the eye tracker. But nothing serious happened for this patient. This is the bottom.
So what do you do? Do you wait until it absorbs, or do you go ahead and
I
fool the machine?
I try. It depends on the refraction. Actually, I try. If the eye tracker is okay, I would go and proceed. If the eye tracker is not working, if it's like -1, -2, so I can, and the patient is cooperative and he can look
So
straight.
you disengage the eye tracker.
Exactly.
Okay.
But if it's an hyperope or have astigmatism, I need to correct the cylinder and need to do some sort of cycle torsion control. I wait until the air bubbles are gone.
There is the small disc that you can actually fool the
Yeah, I
machine
know, I
with.
know.
Okay.
I did it before. Okay, thank you.
Thank you.